Hey everybody, and welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today we're going to be talking about renal replacement therapy. And this is going to be inpatient renal replacement therapy, or the things we do in the hospital. And we're going to be talking about kind of the basics around this. We'll be talking about the different types, whether it's intermittent hemodialysis or continuous renal replacement therapy. We'll dive into peritoneal dialysis just a little bit. We'll talk about the indications for these, emergent versus routine. We'll talk about the timing, the evidence behind the timing, how these different modalities work. We'll dive a little bit into CRRT, continuous renal replacement therapy types, such as CVVH, CVVHD, CVVHDF, and then we'll go from there. For those of you new to this channel Whiteboard Medicine, we try to provide hopefully good medical education episodes here. We also dive into the world of public health news too. We'd love for you to subscribe. We also have a Patreon page, which we post study guides, practice questions, and kind of public health updates. We have a free weekly newsletter and a YouTube members page where you can actually get early access to all these videos, as well as some other perks. So we'd love for you to check those out, whether you're listening to this in podcast form or watching it in video form. Also, quick disclaimer, obviously none of this is intended to be acted upon as medical advice. At the very end of this episode, there will be the full disclaimer. Please listen to that, or you can find it in the description. No further ado, enough of the shameless plugs. Renal replacement therapy, basics, indications, types, timing, all that good stuff. So starting with, what is renal replacement therapy? When we're talking about RRT, which is not in this video the rapid response team, it is renal replacement therapy, what are we actually talking about? Well, renal replacement therapy refers to kind of the technique. So it's an umbrella term, kind of this large general term that refers to the replacement of the function of the kidneys. So these are modalities and things we can do to take control of the function of the kidneys to a large degree, whether that's from acute renal failure or chronic renal failure, sometimes known as end-stage renal disease. And the function of the kidneys, as many of us know, are several-fold. One is fluid removal, right? We all urinate. You got to get rid of some fluid from the body. Electrolyte balance, potassium, sodium, chloride, all the electrolytes you can imagine. We'll talk more about bicarbonate below. Acid-base regulation is a big one. Okay, our kidneys help us with the buffering system, primarily through bicarbonate, HCO3. And then toxin and solute clearance. There's all these kind of toxins floating around the body, small molecules, big molecules, and our kidneys help us clear those toxins. We urinate them out. In addition to that, different drugs are primarily renally excreted. So if we don't have adequate kidney function, we can't actually excrete those drugs, so they build up in our system. So there's a lot of functionality to the kidneys. It's a critically important thing, and when they fail, we can't live without them, which is why somebody much smarter than we are came up with different modalities of renal replacement therapy. So renal replacement therapy is used primarily for several different things. One is acute kidney injury or acute renal failure. Something has happened to those kidneys. Maybe you're in shock, maybe you're in septic shock, where you get all this organ injury leading to acute renal failure. Maybe you have a primary renal problem, nephrotic disease, nephritic disease, an autoimmune disease, lupus, all these things can affect the kidneys and lead to acute kidney failure. Maybe you're profoundly dehydrated because goodness forbid you got lost in the desert and haven't eaten or drank anything in days. Maybe you have rhabdo, where your CPK increases from muscle breakdown, which leads to myoglobin, a molecule that leaks out of those injured muscles and can clog up those kidney nephrons, and that causes renal failure. So lots of different reasons for acute kidney injury, acute renal failure. And when you're in this and your kidneys can no longer work in a way that can sustain your body, we'll get into the emergent indications actually below. But acute kidney injury. People with chronic kidney disease or end-stage kidney disease, also known as end-stage renal disease or ESRD, also need dialysis. Many patients are on dialysis in the outpatient arena. They go 3 times a week. Most are Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. There are some variability to this. Some people need it a little bit more, some people need it a little bit less. But those with just chronic kidney disease that's progressed over time to the point where they are in end stage often need dialysis. And when they come into the hospital, we need to continue that dialysis, right? Because those patients can't live without the dialysis because their kidneys are unable to sustain them on their own. And then the last indication, which is probably one people maybe don't think of right off the bat, but it's critically important, and it's toxin removal. Okay, when you have a buildup of toxins, let's say you have intentionally overdosed on aspirin, also known as salicylates, that can be a life-threatening, that can kill you. And in severe cases, for salicylate toxicity, you actually have to do dialysis because that dialysis will remove some of those toxins, which we'll talk more about. We're going to come up with a whole bunch of episodes on renal replacement therapy. So subscribe, stay tuned, because we'll be talking specifically about that. Or let's say you took too much of your lithium, or you're unfortunately, have alcohol use disorder and you ran out of alcohol, so you drink something like ethylene glycol, toxic alcohol that you can find in different things. All of those, in the most severe cases, can lead to the need for emergent renal replacement therapy, not because your kidneys have failed, although sometimes they do from these things, but because that renal replacement therapy will remove those life-threatening toxins from your body and potentially save your life. Indications for renal replacement therapy in the ICU, and we can expand this to just kind of emergent indications in the inpatient setting in general. So we can think about this list as the emergent needs for renal replacement therapy. And this is something we all should know, but it's also something frequently tested on exams. And it has a nice mnemonic with it. It's A, E, I, O, U, right? We can all remember that, the vowels, A, E, I, O, U. And the A stands for acidosis. We said one of the critical functions of the kidneys is to regulate acid-base balance primarily through bicarbonate buffering systems. And if you have severe acidosis and really severe acidemia, acidosis being low bicarbonate, whereas acidemia is where the blood is acidotic. So this is a low pH. These are slightly different, right? Because we can be acidotic, we can have a low bicarbonate and not be profoundly acidemic. Our pH can be about normal because our respiratory system auto-regulates our acid-base status too. So we breathe faster, breathing off carbon dioxide, and that helps keep the pH normal. We actually have a whole series on acid-base stuff, so definitely check that out. We'll list it in the video or podcast description below. So profound acidosis is the A in AEIOU. The E stands for electrolytes, and this has to be profound electrolyte derangements. Our kidneys, as we talked about, help us regulate our electrolyte balance. And the one we run into most often is refractory hyperkalemia or elevated potassium. And the reason this is one of the ones we think about when you need emergent dialysis is because hyperkalemia can be life-threatening. You can die from hyperkalemia. It can lead to your heart going into irregular rhythms and actually stopping. So when it comes to the A for acidosis, severe metabolic acidosis, some people say pH less than 7.1, although that's, context specific. And then for electrolytes, refractory hyperkalemia, some people say a potassium greater than 6.5 with EKG changes, but this would have to fail medical therapy. And there isn't a, true cutoff for potassium where you have to do this. I think if you've treated aggressively from a medical therapy standpoint, you still have refractory hyperkalemia above 6, certainly above 6.5 with any persistent EKG changes, I think it's reasonable to do emergent hemodialysis. We'll probably have to do a video on hyperkalemia. That might be a good one. Let us know in the comments if that's something you want to see, because when we were talking right now about EKG changes, we were about to dive into what all those are, but that's probably outside the specter of this episode. So we can talk about hyperkalemia certainly in a future episode if people are interested. So that's the A for acidosis, E for electrolytes, I stands for intoxication. And this is really the toxin removal portion of dialysis. So if you have a life-threatening level of a dialysable toxin. Again, this is toxic alcohols like methanol, ethylene glycol. We don't usually dialyze for isopropyl alcohol, although that's another toxic alcohol. Different medications like lithium, salicylates from aspirin. All of these things sometimes need emergent dialysis. Now, when you dialyze patients who have ingestion, intoxication from these is very compound or medication specific, right? When we choose to pull the trigger on salicylate toxicity versus lithium toxicity versus toxic alcohol toxicity is all going to be slightly different. But if you have someone who has toxic ingestion of one of these dialysable toxins, that is an indication for emergent dialysis. But the key here is it has to be a dialysable toxin, which not every toxin is, okay? So again, A for acidosis, E for electrolytes, particularly hyperkalemia, usually a potassium greater than 6.5 with EKG changes, although that is not a firm rule. I for intoxication from a dialysable toxin. The O stands for overload. This is refractory volume overload that is leading to real end organ injury, usually hypoxia or hypoxemia or low oxygen levels. So if your kidneys are not working enough to urinate off enough volume and you're building up volume, it's getting in your lungs causing pulmonary edema and hypoxemia, that can be a reason to dialyze, certainly. Now, you would usually do a diuretic challenge, so you'd give a diuretic like furosemide or bumetanide or torsemide to see if you could get those kidneys to start urinating. And if you give a diuretic challenge, give escalating doses of that diuretic, and there's still not adequate urine output to fix the volume overload, that's certainly a reason to do emergent dialysis. And then the U in AEIOU is uremia. Severe uremia or increased BUN can cause a lot of complications. It can cause things like pericarditis, it can cause encephalopathy, it can cause uremic bleeding, right? Uremia actually affects platelet function, so high BUNs lead to worsening platelet function, and as such you can have problems with forming a clot, which then can lead to bleeding. So in the AEIOU strategy, the mnemonic for emergent indications for renal replacement therapy, the A, as we said, is acidosis, severe metabolic acidemia, pH less than 7.1, unresponsive to medical therapy is a consideration. E stands for electrolyte derangements, particularly refractory hyperkalemia. Some may suggest a K above 6.5 with EKG changes refractory to medical therapy, but that's not a firm rule. The I stands for intoxication. This is dialysable toxins like methanol, lithium, salicylates. The O stands for overload, refractory to diuretic challenges, and the U stands for uremia. This is a severe BUN elevation leading to complications like uremic encephalopathy or pericarditis or bleeding. But what are the three different types of renal replacement therapy? And we're going to break it up into primarily three types. The first and the one probably best known is intermittent hemodialysis, or IHD. This is what people are on in the outpatient setting too. Right, it's where you go 3 times a week. You sit in your dialysis chair and you get dialyzed. It usually lasts duration about 3 to 4 hours. And again, it's usually 3 days a week. Schedules are often Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. But it can be as few or many days as a patient requires, which is variable depending on the patients. The mechanism that intermittent hemodialysis uses is diffusion-driven solute clearance using a dialyzer. And in future episodes, we're going to dive into what this means, but we do just want to briefly talk about it because we're going to be talking about diffusion versus convection. These are two different concepts related to how the dialysis works. And we'll draw maybe some, what we'll say are terrible little drawings here, but we're going to draw them anyways. Let's do this. If you're listening to the podcast, apologies. We'll narrate what we're drawing best we can, but you can check out the video if you need to. It'll be linked. So diffusion is when there is blood pulled out of the body and it runs into a filter. And on one side of the filter is the blood, and on the other side of the filter is dialysate. And this is a solution, you can choose the components of it, that runs parallel to the blood. And there's these tiny little pores. And what happens is solutes and molecules in the blood diffuse down a concentration gradient into the dialysate. And that is how it clears the blood. Okay, so it's a concentration gradient driven diffusion. So if you have too much potassium, some of that potassium is going to diffuse into the dialysate down the concentration gradient. So then what comes back to the body has less potassium. And you can apply that to all sorts of, electrolytes and little molecules and all that kind of stuff. Okay, this is different than convection. Convection is when you actually have a flow-related sorry, we were just doing our second diagram here. A flow-related gradient isn't the right word, but kind of a pressure difference where the blood is flowing next to a filter, and just because of the flow and the pressure, some of that blood travels through these small pores, and you usually get water, and then little molecules follow that water that then gets discarded, and what comes back to the body has less water and less of those molecules. Okay, so there isn't a dialysate that is kind of pulling molecules down a concentration gradient. Instead, the blood flowing by this filter just by sheer flow and pressure has some of that water and molecule come out of the blood past the filter into what we call the effluent, which is just what's discarded. So it's water and small molecules that kind of get pushed into that effluent to quote unquote purify the blood. So intermittent hemodialysis is diffusion. It uses the dialysate, and it's clear small molecules and solute by them diffusing down a concentration gradient. You can use it in stable patients and in the outpatient setting. The challenge is there's lots of volume shifts that happen, okay? Because you are dialyzing someone over 3 to 4 hours, and usually taking, you can choose how much, but you're usually taking 1 to 2, sometimes even 3 liters of fluid out of the patient's body, okay? And that helps with rapid clearance of electrolytes and toxins, but it means there's a lot of volume shifts. So if someone's unstable, it's really hard to use intermittent hemodialysis. So the cons are hemodynamic instability with due to the rapid fluid shifts, but it works the fastest too. So you got to sometimes walk the line. If you have someone with refractory hyperkalemia, the fastest way to get their potassium down is intermittent hemodialysis. This is much faster than what we'll talk about in a second, which is continuous renal replacement therapy. If you have someone with a toxin, right, they have a salicylate overdose or an aspirin overdose, the fastest way to clear that is going to be intermittent hemodialysis. Whereas if you just have someone who you want to get volume off of, or they're just a little acidemic, no big rush, then continuous renal replacement therapy does a fine job, but it just takes longer than intermittent hemodialysis to clear these solutes. All right. So continuous renal replacement therapy is our next type of renal replacement therapy. So as the name implies, continuous. This is a 24/7 continuous therapy. It just keeps running. We said intermittent hemodialysis is usually something like 3 to 4 hours, whereas continuous renal replacement therapy is running 24 hours a day. And there's different types of continuous renal replacement therapy. We're going to dive into these in a future episode, so we're just going to mention them here. But the 3 main different types of continuous renal replacement therapy are CVVH, CVVHD, and CVVHDF. This is very confusing, which is why I want to do a whole separate episode on it. But CVVH stands for continuous veno-venous hemofiltration. All the CVV stand for continuous veno-venous, so we can kind of take that out of the title because then we could focus on the parts that are different. So CVVH, that H stands for hemofiltration. Okay, and this uses convection to clear fluid and solutes. Remember, we said convection is where the flow and the pressure forces some water out of the filter, out of the blood through the filter, and that drags some solute with it, and that's how it purifies the blood. Where we said diffusion is where there's actually dialysate running parallel to the blood, and that some of the solute in the blood diffuses down a concentration gradient into the dialysate. So these are 2 different types of ways to clear solute. So CVVH, the H stands for hemofiltration, which is convection driven. CVVHD, we said CVV just stands for continuous veno-venous, so we could forget that. The HD stands for hemodialysis. Okay, not hemofiltration like CVVH, but hemodialysis, HD. And hemodialysis, as we talked about even for intermittent hemodialysis, uses diffusion. So this uses a dialysate that runs parallel, and solute in the blood goes down the concentration gradient into the dialysate. Whereas CVVHDF stands for hemodiafiltration. Okay, so this is a combination of hemofiltration and hemodialysis, hemodiafiltration. It uses both diffusion and convection to clear solute and fluid, so it's mixed. So these are all continuous renal replacement therapies. In that future video, we'll dive into when we use each one of these because it's a little bit complex. So the use of continuous renal replacement therapy in general is really for hemodynamically unstable patients. Because as we said, for intermittent hemodialysis, you got to take a lot of volume. It goes really quick, so that can cause worsening instability. Whereas continuous renal replacement therapy, you really only have about 100 to 300 cc's of blood in the dialysis circuit at any one time. So it is slower, which allows you to maintain more stability if you are already unstable to start. So this is like a hypotensive patient on vasopressors in the intensive care unit would be the patient you think about continuous renal replacement therapy. Pros of it is its gentle fluid removal, stable hemodynamics. Now, do remember, you still do have to take 100 to 300 cc's of blood into the circuit. So it's much more stable, but there's still some patients, if you are profoundly sick on multiple vasopressors and kind of that multi-pressor refractory vasoplegic shock, you still might not be able to tolerate CRRT. It's your only shot. You certainly wouldn't tolerate intermittent hemodialysis, but even though CRRT is much more stable, it still can lead to worsening instability if you're super, super sick. The cons of CRRT is that you can have clotting of this circuit because that fluid goes more slowly through it. That blood goes more slowly through the circuit. So sometimes these patients need anticoagulation. Sometimes that's something like heparin. Sometimes it's something called citrate, and we'll talk more about that again in that future episode. And that it's continuous, right? So it's a big burden on nursing. You have to have a machine in there the whole time. These are all resources that you're occupying continuously, rather than intermittent hemodialysis where you're just occupying them for 3 to 4 hours. But patients in the intensive care unit, many of them are on CRRT. All right, next is kind of this little hybrid maneuver. It's called SLED. This is sustained low efficiency dialysis. And you can think of it as like a combo of intermittent hemodialysis and continuous renal replacement therapy, so IHD and CRRT. It's about 6 to 12 hours long. So it's slower than IHD, which is 3 to 4 hours long, but it's obviously shorter than CRRT, which is 24 hours long. So it's kind of a combination of the two. All right, some ICUs like it because if you have limited CRRT access or you don't want to have someone occupied for 24 hours on a circuit, this is kind of a best of both worlds sort of thing where you run them slower so you have more ability to remain hemodynamically stable, but you also are not occupying a machine and nursing and all that for 24 hours on a CRRT machine. But because it's 6 to 12 hours, you still can get more hemodynamic instability than pure CRRT. So if you were to rate like stability from what is the most stable or least likely to cause instability, continuous renal replacement therapy would be the least likely to cause instability. Next after that would be SLED, which is this slow, low efficiency dialysis. And after that would be intermittent hemodialysis. So CRRT is the most stable, followed by SLED, followed by IHD. And then we just want to do a shout out to peritoneal dialysis. For those of you that don't know what this is, it's actually really interesting. The patients have a catheter that goes from the outside world into their belly. We're terrible at drawing. Let's see if we can. Here will be someone's belly. Here's their legs down there. Their head is up here somewhere. Yay, human. This is their chest. Here's their belly button. They have a catheter that sits in their belly, right? It's going actually in their belly, and it stays there. And what you do is you instill fluid, special dialysis fluid, and you instill it so it goes into their abdominal cavity and it sits in there. And it actually creates concentration gradients across the intestines and things and helps filter the blood that way. And then after a certain period of time, you drain you drain all that fluid out, and it gets rid of all the solute and stuff that has diffused into the intra-abdominal cavity and that fluid you put in there. So it's really interesting. A lot of patients do it because you can do it at home. You can do it while you're sleeping. There's all sorts of different ways, because if you're in the outpatient world and you're on dialysis, obviously going to a dialysis center 3 times a week for 3 to 4 hours can be really taxing. So this is a way where you can, maybe have a little bit more convenience. We rarely use it in the ICU. Now, in resource-limited settings that don't have access to dialysis, certainly something to consider, we suppose, but we don't have any exposure to that. But it's not commonly used in the ICU. The pros are no vascular access is needed. The cons, it's slow. The solute clearance is slow. You have a catheter going into your belly, so there's a constant risk for peritonitis. We probably actually see it most in the ICU when someone gets sick from peritonitis who's on peritoneal dialysis. But it is something that does happen, so we wanted to shout it out as a renal replacement therapy option. So those are the 4 main renal replacement therapy options, really 3 main ones with a caveat, and that's intermittent hemodialysis. It's the fastest, but leads to the most hemodynamic instability, followed by SLED, sustained low efficiency dialysis. It's kind of middle speed, 6 to 12 hours, and is more stable than intermittent hemodialysis, but still can lead to instability. And then continuous renal replacement therapy, which is the slowest. It goes for 24 hours, but is the most stable. And then a little shout out to peritoneal dialysis. So what about the timing of renal replacement therapy in acute kidney injury? What does the evidence say? When should we be starting patients on renal replacement therapy? Let's say someone comes in shock. Sorry, I had to get a swig of the coffee naturally. Someone comes in shock and they have acidemia, they have acute kidney injury, they have some maybe slight hyperkalemia. When do we pull the trigger and say, we got to put a dialysis catheter in them? They need to be dialyzed. Do we do it early? Do we do it late? What do we base it off of? Well, there's some debate here about early versus late initiation of renal replacement therapy. And this most often happens in the intensive care unit, but it can happen anywhere in the hospital. And there's been a number of trials that has assessed this. The general trend kind of says that it needs to be individualized. Okay, there's some push for early initiation, and we'll talk about what that means, but this hasn't really been borne out in additional studies. So what we have here, we've listed the major trials. Obviously read all these on your own, interpret them, and make a decision on what you want to do. It looks like in our year the numbers are lower, but the 5 biggest trials, the kind of main trials on this, are called ELAINE, Acute, Ideal ICU, and START AKI. And the ELAINE and Acute were in 2016, Ideal ICU and START AKI 2018 and 2020 respectively. Sorry about that little typo there. And they looked at different populations with acute kidney injury. And what they seemed to find, so what they were studying was early versus late initiation of renal replacement therapy. But what that means is really important. So all of them chose kind of a different marker of what early means. So in ELAINE, early renal replacement therapy was if you got to AKI stage 2, which is a certain stage of acute kidney injury. Y'all can look it up. It has to do with creatinine changes in urine output. They would start that continuous renal replacement therapy within 8 hours of getting to AKI stage 2. And late is you needed an emergent indication, one of those A, E, I, O, U indications. So early is getting within a certain stage of acute kidney injury, and late is only starting dialysis once you have an emergent need. And what they found in ELAINE, in this surgical ICU population, was there's actually a decrease in mortality in patients they started early dialysis on. So then there's this whole thing, should we be doing early dialysis? But the follow-up trials, Acute and Ideal ICU, which looked at slightly different populations. Acute looked at medical and surgical ICUs. Ideal ICU primarily looked at septic shock patients. But they found no mortality difference between early and delayed renal replacement therapy in either of these. And in Ideal ICU, there's actually a trend towards harm with early renal replacement therapy. So ELAINE was like, oh, maybe early is better, ? In this surgical ICU population. But Acute and Ideal ICU said, nah, there's no difference really. And maybe there's even a trend towards harm in the Ideal ICU trial. Then there was the START Acute trial, which was in 2020, and this also showed no difference in mortality between early and, late is not the right word. We should use early and delayed renal replacement therapy, I suppose. So what we do know is if you wait and you don't start early, less patients do need dialysis. Not every patient that you would have started early renal replacement therapy on ends up needing renal replacement therapy if you wait until they have an emergent need. Some get better, even if you don't think they will. And it looks like there's no big mortality difference. So this is certainly an individualized decision, one that is partners with the primary team taking care of the patient in nephrology and the patient as well, of course. But I think most people do not do early renal replacement therapy. Most people wait for one of those emergent indications for renal replacement therapy, whether it's acidemia, electrolyte derangements, if they, goodness forbid, ingested something, have volume overload or severe uremia. All right, so summary of the timing of evidence, we just want to put this in here. Early renal replacement therapy may be helpful in a select surgical patients based on the ELAINE trial, but that's tough to say for sure. Delayed renal replacement therapy, aka until you get an emergent indication like the AEIOU criteria, is safe and avoids unnecessary dialysis in many patients, right? Some of those patients will get better and not need dialysis. So individualize it based on volume assessment, electrolyte derangements, and clinical course. So today we're going to be talking about continuous renal replacement therapy, or CRRT. Specifically, we're going to kind of dive into the basics of this. We're going to talk about the different components of renal replacement therapy, continuous renal replacement therapy. We're going to talk about the different types, CVVH, CVVHD, CVVHDF, are all different kind of types under the umbrella of continuous renal replacement therapy. We'll talk about the parameters. We'll dive into how to use CRRT. We'll dive into the different components, all that good stuff. So couple quick plugs. We have a high yield Patreon page where we'll upload the study guide of this video as well as practice questions. We also will upload that to our YouTube members page, so definitely check those out. They're linked in the description. And then we do have a weekly free newsletter that we send out. This is primarily focused on public health and emerging infectious disease. So we'd love for you to check any of those things out if you so choose. And we obviously have a podcast and a YouTube channel, depending on whether you're listening to this or watching it. So all that will be linked in the episode description. And then just last thing, as always, this is not intended to be acted upon as medical advice. The full disclaimer is at the end of this episode, also in the episode's description. So definitely check that out in its entirety. All right, let's dive in. CRRT. What is CRRT? Well, CRRT stands for Continuous Renal Replacement Therapy. And this is a group of dialysis modalities used primarily in critically ill patients with AKI who are hemodynamically unstable. Now, you can have patients who, instead of AKI or acute kidney injury, have end-stage renal disease, ESRD, and are on intermittent hemodialysis at home or in the outpatient setting, but now they're critically sick and hemodynamically unstable, and as such they require this slow, continuous fluid and solute removal, that they're not able to tolerate their intermittent hemodialysis anymore. CRRT mimics the kidney's continuous function over 24 hours. It's continuous. It goes for 24 hours. Unlike intermittent hemodialysis, which usually runs for 3 to 4 hours, and is much more kind of hemodynamically disruptive to patients. So CRRT, continuous renal replacement therapy, we usually use in our critically ill patients with hemodynamic instability. It is for either acute renal failure or end-stage renal disease who is now critically sick and needs dialysis, and it's slow, it's continuous, and it runs over 24 hours. So why use CRRT in the ICU? Well, as we mentioned, you can do intermittent hemodialysis in the intensive care unit, of course. So when do we use continuous renal replacement therapy, CRRT? As we mentioned, hemodynamic instability is probably the biggest one. Because it's continuous, there's slower removal of fluids and solutes, so hypotension is better tolerated. Now, make no mistake, those that are critically ill, those on multiple vasopressors, this still can worsen their hemodynamic instability. This is not completely benign from a hemodynamic standpoint, but it is much more stable than something like intermittent hemodialysis or even slow, low efficiency hemodialysis, SLED, which we've talked about in previous episodes. Again, linked in that nephrology playlist in the description of this episode. Volume overloaded patients are another subset because we actually can get pretty fine control of their fluid balance. On CRRT, we can, set them. We want them to have net negative 100 cc's per hour. So this is that their ultrafiltrate, their UF, how much fluid we're removing from the body. We want it to be 100 cc's removed per hour. That is just discarded. So you have really kind of fine control over the volume balance. Cerebral edema is another one. CRRT is very gradual. It's very slow. So the solute shifts that occur with continuous renal replacement therapy is much slower and gradual, and some would suggest that this helps patients with intracranial injury because there's not this fast movement of solutes. Now, this is a little in the gray. It's not totally clear, but a lot of folks kind of abide by this. And then, obviously, severe acute renal failure with multi-organ dysfunction. CRRT, sometimes the best modality given that hemodynamic instability. So what are the components of continuous renal replacement therapy? Well, you obviously need vascular access. You need some way in which you can hook someone up to the CRRT machine. And this is typically a large bore double lumen catheter. We most often place it in the neck, in the internal jugular vein, or in the groin, in the femoral vein. And these two lumens, one of them draws blood out of the body to the dialysis machine, and then the other one sends post-dialysis blood from the machine back into the body. And they need to be large bore. A lot of people use verbiage like trialysis is a big one that we sometimes will use to place this. They need to be large bore because they need to have a really high flow rate. Sometimes like 100 to 200 cc's per minute of blood flows through here. So they can't be small. They got to be large bore. And there's particular dialysis catheters that we often place to do this. You need a pump. Right? The machine needs a pump. The pump draws the blood through the filter. Again, typically 100 to 200 cc's per minute of blood flow. That is literally flowing from the patient into the dialysis machine and then out of the dialysis machine back into the patient. You also need a filter, often called a hemofilter. This is that semi-permeable membrane where solute and water exchange occurs. So this is the membrane that the blood passes by and through that helps purify the blood, right? It helps remove solute from the blood. It helps remove water from the blood. This filter, this semi-permeable membrane, is critical for the function of dialysis. Then you need either replacement fluid or dialysate. And in one of our previous episodes, we dove into what these two are. We're going to briefly touch on them here, but definitely check that out, okay? Again, it's linked in that nephrology playlist under CRRT. But the replacement fluid is the fluid that we pump into the patient's blood to then be given back to the patient. And the reason we do this is for some modalities of CRRT, particularly, and we'll talk more about all these things, CVVH, which is continuous veno-venous hemofiltration. It uses something called convection. Okay, convection is where you pump blood past this semi-permeable membrane, and water from the blood and solutes diffuse out of the blood into a separate chamber that then is discarded. And you sometimes then need to give replacement fluid back into the blood to make up for some of these losses. And this is something you can calculate. You can give it in a couple different ways. This says before or after the filter, which again, we dived more into in that other episode. Then dialysate is another possible fluid you need. And this is for CVVHD, or continuous veno-venous hemodialysis. Again, we'll talk more about these modalities, which uses diffusion, which is when you pump blood past this filter, this membrane. The blood comes down, B for blood. The dialysate is traveling parallel, but counter current. And essentially the dialysate creates a concentration gradient between the blood and the dialysate, so then things diffuse down their concentration gradient into the dialysate, which is then discarded. So depending on the modality of CRRT you're using, you'll need either replacement fluid, dialysate, or both. And then many circuits need anticoagulation, and the reason is because your blood flow rate is much slower for continuous renal replacement therapy than it is for intermittent hemodialysis, and with slower blood flow, you have a higher risk of clotting. Now, this is all either citrate or heparin. Both of these can be used, and not all CRRT setups use anticoagulation, but if you don't, you run the risk of clotting your circuit. So many of them use citrate or heparin, but you can do this without anticoagulation. You just run the risk of clotting your circuit. All right, 4 types of CRRT. This is where we're kind of diving into these different modalities, and we're going to talk about each individual one in detail. So we're just introducing them right here, and then we'll dive more into them. So there's 4 subtypes, and really it's like 3 subtypes plus another one that's sort of like CRRT. And if you didn't notice, CRRT is an umbrella term. Continuous renal replacement therapy is an umbrella term that then includes these, I guess we'll say 3.5 different modalities, which are different types of CRRT. And they're distinguished by their mechanisms of solute removal, okay? So when we're looking at these, the first 3 are CRRT modalities, and then this last one, SCUF, is a CRRT, but just a little bit different in terms of how it works. So focusing on the first 3, you'll see CVV in all of them. CVVH, CVVHD, CVVHDF. And I want you all to just ignore the CVV part of this, because the CVV just stands for continuous veno-venous, right? It just means continuous blood drawn from one vein into the machine and then put into another vein, continuous veno-venous. And that just leaves us with less letters to focus on. So CVVH, if we ignore the CVV, it's really just H. CVVHD is really just HD. CVVHDF is really just HDF. Okay? CVVH, the H stands for hemofiltration. And this is important. HD for CVVHD stands for hemodialysis. And then HDF for CVVHDF stands for a combination, hemodiafiltration, a combination of dialysis in the dia, and then obviously filtration in the filtration. So you're starting to see some patterns emerge now, right? Hemofiltration, hemodialysis, and hemodiafiltration. And the reason there's different verbiage here is because the way in which the CRRT modalities work is different. They're slightly different for how they get rid of solute. CVVH, which is hemofiltration, uses convection. So anytime you see hemofiltration, I want you to equate in your brain to convection. Whereas hemodialysis, CVVHD, the hemodialysis stands for diffusion. Anytime you see hemodialysis, equate it in your brain to diffusion. Which then leaves hemodiafiltration, which is a combination of dialysis and filtration. So it's a combination of diffusion and convection. All right, does that start to register a little bit? Obviously still very confusing, but the convection, diffusion, filtration, dialysis are all kind of patterns you could pick up in your head that then help you clue you in later on. So just to say it quick, because we're going to dive into each of these types, we just wanted to take a moment to pause and talk about the difference between convection and diffusion. So for those listening to the podcast, we are going to draw a little diagram here. Apologize, but we'll vocalize it best we can. So the top is going to be diffusion, top diagram here. And the bottom diagram here is going to be convection, okay? And what we have here is the middle line is a filter. This left side is going to be blood. And this right side will change depending on the modality we're talking about. So essentially, blood is drawn into the dialysis machine, and it runs by this filter. And this filter, as we said, is a semi-permeable membrane. So that happens in both diffusion and convection. Blood is taken into the semi-permeable membrane. Diffusion, though, what happens is the semi-permeable membrane has these really small pores in it. And what runs parallel to the blood is dialysate fluid. Okay, it runs countercurrent, but parallel to the blood. And as this blood runs by this filter that is also in contact with the dialysate, the solutes in the blood will diffuse across this filter down a concentration gradient. So if there's 10, molecules hypothetically in the blood, and there's 2 molecules hypothetically in the dialysate, then these molecules will diffuse into the dialysate until there's 5 on each side, right? This is diffusion. It goes down a concentration gradient. And this dialysate fluid then just gets rid of it. It's discarded. And that is how you clear solute in diffusion-based CRRT modalities. And as we said, diffusion, equate it to dialysis, which would be CVVHD, right? Continuous veno-venous hemodialysis, and CVVHDF, which is continuous veno-venous hemodiafiltration, but the dia portion of that is dialysis. So these two use diffusion. Convection is different. Okay, convection blood runs parallel to the semi-permeable membrane, but the blood flow and the pressure actually forces plasma water out of the blood through these pores into this other chamber. And what happens then is solute follows. There's some solute drag that comes with this water. And that is how it gets rid of plasma water and solutes. It's more of a hydrostatic pressure with semi-permeable membrane leading to plasma water going through this membrane and dragging solutes with it. And then this is discarded. So in convection, there's no dialysate. Okay? There's just this semi-permeable membrane that water from the plasma goes through, and it drags solute with it. Remember, convection, we said we equate that to hemofiltration. So this is for CVVH, continuous veno-venous hemofiltration, and CVVHDF, right? HDF is hemodiafiltration. So the filtration portion of that is all convection, okay? So that's going to come into play a little bit more when we dive into each one of these different CRRT modalities. SCUF is its own beast. So SCUF is ultrafiltration only. This is only for fluid removal. There's no dialysate. There's no replacement fluid. It is just fluid removal, ultrafiltration. You can remove a lot of fluid this way, though. So we don't use SCUF all that often. The only time we can really think that you might consider using it would be if a patient was just profoundly volume overloaded and you just wanted to remove a bunch of fluid, but it's not commonly used. All right, let's go into these modalities a little bit more, starting with CVVH. And even though CVVH would be nice if it was CVVHF, it is not, but it stands for continuous veno-venous hemofiltration, right? And hemofiltration, we said, anytime we see filtration, we should correlate it with convection. So the primary mechanism of CVVH is convection. That's how it gets rid of solute. So there's no dialysate. This is convection. The blood flows past this membrane, and the hydrostatic pressure leads to plasma water going through the membrane, and that drags solute with it. So that's how it works. Plasma water and solutes are dragged across a semi-permeable membrane, also known as solvent drag. You do need a replacement fluid here. And this is a fluid that you can make up with different components. And this helps you maintain your fluid balance because remember, you're dragging plasma water across this membrane to then be discarded. So you're getting rid of plasma water. And you then replace this with your replacement fluid. And you can either do that pre-filter, so you can essentially mix, excuse us, let's get a drink quick. Our bad. You can essentially mix the blood with your replacement fluid and then have it pass through the filter. This prolongs filter life, but it does reduce clearance slightly because you're kind of diluting out that blood. Or you can have a replacement fluid post-filter. So the blood goes by this filter. That filter obviously does the solvent drag where plasma water and solutes are dragged across and discarded. And then you mix what's left of the blood with the replacement fluid. This stands for better solute clearance because you haven't diluted the blood before it passes that filter. But it does also lead to shorter filter life. So this is best for patients with sepsis, inflammatory mediators, hemodynamic instability. Convection, people say, is better for kind of larger solute molecules, things like myoglobin, cytokines, all that kind of stuff. Okay. CVVHD, continuous veno-venous hemodialysis, right? We said anytime you see dialysis, think diffusion. All right. Whereas again, anytime you see hemofiltration, it's convection. So primary mechanism for CVVHD is diffusion, which, as we said, solutes move across that membrane along a concentration gradient using that dialysate fluid. The dialysate flows countercurrent to the blood, and there's a certain flow rate of the dialysate fluid. The higher the dialysate fluid flow rate, the more efficient your removal of solute is going to be, which makes sense because the solutes are moving across a concentration gradient. So if you let the dialysate get totally saturated with solutes, that concentration gradient goes away. So if the dialysate is flowing faster, there's going to be less there's going to be better preservation of the concentration gradient because that dialysate will not have time to get a bunch of the solutes in it because it'll just keep flowing by quickly. This is best for small solute clearance, urea, creatinine, and mild fluid removal, so it can't remove as much fluid. So CVVHD is better for small molecules. CVVH is better for larger molecules. This then gets into the combination maneuver, CVVHDF, continuous veno-venous hemodiafiltration, right? Why make any of these words easy? But the more you think about it, you probably have to watch this video a couple times, the more this starts to register. So this has both dia, which is for dialysis, which is diffusion, and filtration, which is for convection. So it's both diffusion and convection, and that's the mechanism of CVVHDF. So it combines CVVH, which is hemofiltration, which is convection, and CVVHD, which is hemodialysis, which is diffusion. And that means it uses both a replacement fluid, which is most typical of CVVH, because it uses convection, right, which has that plasma water with solvent drag, and CVVHDF uses dialysate, because it has a hemodialysis, which uses diffusion, which needs a dialysate running. So it's a combination of those, CVVH and CVVHD. It's best for maximizing clearance of small and larger molecules, excellent in critically ill with high toxin load or multiple indications. I think many people in the intensive care unit kind of use CVVHDF as a standard, which is nice. And then SCUF, as we mentioned, is this kind of enigma. It's slow, continuous ultrafiltration. It just uses ultrafiltration to remove fluid only. It's pure volume removal. There's no dialysate. There's no replacement fluid, but you can take off a lot of fluid. You can take off, 100 to 300 cc's per hour, sometimes even more. And this is really only good for fluid overload patients without significant need for dialysis otherwise. They don't have significant electrolyte derangements or acid-base disturbances or uremia or what have you. So the operational parameters that we should keep an eye on and think about, and we've talked about all these in some of the introductory videos, so you can definitely check those out. But blood flow rate is important. This is the rate of blood that's being removed from the body and running through the dialysis machine. It's usually 100 to 200 cc's per minute. And this is a lot lower than intermittent hemodialysis, and this is what really reduces that hemodynamic stress. But it is 100, 200 cc's per minute, so you are removing blood from the body, so it will cause some hemodynamic instability, but much, much less than other dialysis modalities. The effluent rate is the amount of fluid kind of being discarded. This is usually a combination of the ultrafiltrate, of any dialysate that's running through, sometimes of even any additional fluid, replacement fluid given, depending. The thing with the effluent rate is this is how you kind of dose your dialysis therapy, and you usually choose 20 to 35 cc's per kilogram per hour. Some stay starting at 20 to 25, but 20 to 35 cc's per kilogram per hour. This is how you dose your dialysis, unless you're a nephrologist or some critical care shops have you write your own CRRT orders, but this is a little more complex than just the run-of-the-mill understanding of this stuff. The ultrafiltration rate is patient-specific. This is how many cc's you're discarding of the patient's volume. So if I'm saying I want this patient to, I want to eliminate 100 cc's per hour, I want to essentially say I want them net negative 100 cc's per hour, and that is the ultrafiltration. So the ultrafiltration is negative 100 cc's per hour, which means I'm taking that patient's blood, I'm running it through the dialysis machine, it's filtering out 100 cc's of plasma water, and then it's just discarding it, it's getting rid of it, and the rest is going back to the patient. So that's the ultrafiltration rate. And then the replacement or dialysate rate, 1 to 2 liters per hour, and this, depends on the modality, right? We said replacement fluid is for convection, which is going to be CVVH and CVVHDF, and the dialysate rate is for diffusion, which is going to be CVVHD, and still that CVVHDF, which is a combination, right? Good. One thing to note is anticoagulation in CRRT can be really important. The blood, as we said, blood flow rate is much slower than IHD, so there's more risk of clotting. Most shops will use either citrate or heparin. Citrate is usually preferred if there's bleeding risk present. It's regional. You put it in the dialysis machine itself. It binds to calcium, which then prevents clotting in the circuit. This is just like why you have citrate in blood transfusions, because it binds the calcium and it helps with clotting. Now, Other shops use heparin. That's if there's no contraindication to anticoagulation. Sometimes you got to monitor PTTs. Some dialysis machines can have heparin in circuit, but some you have to do it systemically. Now, if there's a high bleed risk, or if you are okay with a shorter filter life, no anticoagulation is an option, but that filter might clot, which means you might have to replace it, and it might require frequent filter changes, which then limits the utility of your therapy, obviously, because every time you have to change the filter, you have to stop the dialysis, blah, blah, blah. So depending on where you work, you will have different approaches to this. Usually the hospital and all the stakeholders have agreed on some approach, whether that's start with no anticoagulation and then flex to heparin or citrate, or whether that's to start with something like a citrate protocol that you just do for all your patients. CRRT stands for, as we mentioned, continuous renal replacement therapy. This is a form of dialysis, as hopefully many of us know, primarily used in critically ill patients, primarily used in our intensive care units. And most of the time, these are patients with acute kidney injury or acute renal failure, but it can also be for those who are hemodynamically unstable with end-stage renal disease, ESRD, right? Patients who come to the ICU with ESRD and need dialysis, but they're now unstable. What it does is it provides slow and continuous removal of solutes. Really, this is over solutes and fluid over a 24-hour period. It can run 24/7. This helps maintain all those things the kidneys do: acid-base status, fluid status, electrolyte balance, all that good stuff, all those critical functions of the kidneys, of those beans. Okay, so the modalities for CRRT we're going to talk about now, and then we're going to actually revisit these throughout. So this is the introductory statement. If it still doesn't make sense, we're going to talk about each part of this. So the three main modalities of CRRT are CVVH, CVVHD, and CVVHDF. The thing to focus on here is not the CVV. This is obviously present in all three of those modalities. It stands for continuous veno-venous. So to help in understanding, I sometimes suggest people just take the CVV out of their head. And it's really H versus HD versus HDF. And what the H stands for is hemofiltration. The filtration is the important part to focus on. HD stands for hemodialysis, and HDF is a combination, hemodiafiltration, right? So we have CVVH, which is hemofiltration, CVVHD, which is hemodialysis, and CVVHDF, hemodiafiltration. Okay, all three of these are continuous renal replacement therapy modalities, but they all work a little bit different. And the little bit different is based on the mechanism that they use to help kind of quote unquote filter the blood. And the two mechanisms we're going to talk about, and we're going to dive into these more down below, are convection and diffusion. Introducing these topics, and we have a diagram below, but introducing these topics verbally, convection and diffusion. Diffusion is easier to think about. This is where solutes in the blood diffuse down a concentration gradient. It involves dialysate and some other things we'll talk more about. Whereas convection is where flow of blood and pressure force water and solutes through small pores down a filter, and that the water coming out of the blood is dragging the solutes with it. So it's kind of solute drag. And again, we're going to be talking more about these, but all of these continuous renal replacement therapy modalities use either convection, diffusion, or combination. So when we're thinking about the verbiage, hemofiltration, the filtration always stands for convection, whereas the hemodialysis, the dialysis always stands for diffusion. And then the combination, right, hemodiafiltration is both convection and diffusion. So if you, in your brain, if you put Filtration and convection is one. Dialysis and diffusion is one. Then these start to make more sense. So if we're going to wrap this up, CVVH. Remember, we're ignoring the CVV, so the H is hemofiltration, and we said filtration is convection. So it's a modality of CRRT that uses convection, CVVH. CVVHD, we said HD stands for hemodialysis, and we said dialysis is diffusion. So CVVHD is a modality of CRRT that uses diffusion, whereas CVVHDF, HDF stands for hemodiafiltration, a combination of dialysis and filtration. And we said dialysis stands for diffusion, filtration stands for convection, so CVVHDF uses both convection and diffusion. All right, hopefully that was confusing in a way that makes it less confusing later. You'll have to let us know. So key terms and concepts as we continue to define things. We're going to come back to convection and diffusion, I promise. But there's some key terms and concepts just within CRRT verbiage that are important to know when understanding what CRRT is, continuous renal replacement therapy, that umbrella term for all modalities of continuous renal replacement therapy, which, as we said, stands for CVVH, CVVHD, and CVVHDF. So this is CRRT is the umbrella term that then encompasses all three of these different modalities. So key concepts, blood flow rate. So when someone is on CRRT, they have a catheter in one of the large blood vessels, whether it's in their neck or their groin, the femoral vein, the internal jugular vein, the subclavian vein. And that catheter usually has two big ports. And one of those ports draws blood back into the dialysis machine. The other port is post-dialysis blood going back into the body. So the blood flow rate is the actual rate at which blood is pumped through the circuit. So it is how much blood is being pulled out of the body into the dialysis circuit to then be pumped back into the body. Okay? So that's typically 100 to 200 milliliters per minute. So this is high flow rates, right? Lots of blood is being pulled out of the body every single minute, 100 to 200 milliliters per minute. Now, those flow rates are much less than intermittent hemodialysis, which we talked about in a previous episode. Definitely check it out. It's linked in the playlist, Nephrology. It is slower flow rates than SLED, slow, low efficiency dialysis. Again, another thing we talked about. But it's still high. It's about 100 to 200 milliliters per minute. This matters because it determines the volume of plasma available for solute clearance. So we're going to say it again. The blood flow rate determines the volume of plasma available for solute clearance. Higher flow, higher blood flow enhances solute delivery to the filter. This makes sense. Solutes are being cleared across this filter, which we'll talk more about. And the more blood you're flowing to that filter, the more solute delivery to that filter, and the more clearance available of that blood, which is the point of the dialysis. So if you have higher flow rates, you are going to have more optimal solute clearance. Okay, dialysate flow rate. So dialysate is used in two different modalities. If we talk about CVVH, CVVHD, and CVVHDF, can you all guess which two of these uses dialysate? Yeah, the ones that have HD, hemodialysis. So it's going to be CVVHD and CVVHDF because you need dialysate for diffusion. And we said dialysis and diffusion should be kind of two things in your brain that are related. So what the dialysate is it's a solution that comes from, that we put together, a synthetic solution that flows parallel but counter current to the blood. Okay, so you essentially have your dialysis machine that has this filter and blood flows in the dialysis machine past this filter, while at the same time, dialysate flows parallel to, but in the opposite direction of the blood. And what this does is it helps with that concept of diffusion, which is where those small molecules that solute diffuse down the concentration gradient. So if we were just to make this simple, let's say you have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 solutes in your blood, and you have 3 solutes in your dialysate. That 10 solutes in your blood are going to diffuse down the concentration gradient past this filter into the dialysate. And it happens the opposite way too if you wanted it to. Right, you could have more concentration in your dialysate of, say, bicarbonate, and that bicarbonate should actually diffuse into the blood. All right, so it works in both directions. It just goes down the concentration gradient. So the dialysate flow rate is the actual rate at which the dialysate is flowing countercurrent to the blood. This is typically 20 to 25 milliliters per kilogram per hour of total effluent. Effluent is a new term that we're going to be talking about in a second. Okay, so the dialysate flow rate is a rate that is important because just like the blood flow rate, a higher rate increases solute clearance. And we can understand that, right? As we said, your dialysate is a solution that is allowing solute to diffuse across the filter into the dialysate or vice versa. So if your dialysate is moving quickly, your concentration gradient is going to always be maintained because that dialysate is moving quick. So the blood's always being exposed to new dialysate to then have things diffused on the concentration gradient. Whereas if the dialysate is flowing slowly, as solute diffuses into the dialysate, the concentration in the dialysate of those solutes is increasing, so it kind of eliminates that concentration gradient. So if your dialysate is moving slow, you might eliminate that concentration gradient, and then that will stop solute clearing from the blood. Whereas if it's flowing fast, you always maintain that concentration gradient, and it increases solute clearance of these small solute molecules. So that's the dialysate flow rate. So we have blood flow rate and dialysate flow rate. What about the replacement fluid rate? Well, the replacement fluid rate is most important for filtration modalities of CRRT, and we're going to tell you why. So if we list them again, we're being annoying. CVVH, CVVHD, CVVHDF. Which two of these is replacement fluid most important for? If it's most important for filtration or convection modalities. Well, as we said, the H alone stands for hemofiltration. So CVVH and CVVHDF are going to be our two modalities because CVVH is hemofiltration, which has filtration. And we said filtration should always prompt in your head convection. And as we also said, CVVHDF is hemodiafiltration, and it's a combination of filtration and dialysis, but because it has filtration, convection should be in our head. And the reason you need replacement fluid for these convection modalities is because they work different than the diffusion modalities. So the convection modalities, essentially, if we're drawing a similar picture, you have blood flowing through one part of the dialysis circuit, you have a filter, and you essentially have, as your blood is flowing, some weird pop-up came up, apologies. As your blood is flowing through the dialysis circuit by this filter's got very small little pores in it. And some of this blood is being filtered through these pores just based on the flow and pressure, and it is clearing water, but there's solute drag. So then the solutes in the blood, as this water is being filtered out of the blood, some of those solutes follow that water, and they end up in this effluent. This is then discarded. But because in hemodialysis, there's the solutes diffusing across a concentration gradient. So you certainly can get rid of volume with these diffusion methods, but it's just slightly different. Whereas in convection methods, water is being forced through these small pores. So water that's in the blood, obviously your blood has a lot of water in it, and then solute follows that water, and that water and solute is discarded as an effluent. But sometimes you actually need to replace some of the blood volume with this replacement fluid. Okay, so the convection modalities, CVVH and CVVHDF, usually need replacement fluid. And the rate at which the sterile fluid is infused to replace the volume lost through ultrafiltration. Because ultrafiltration is what it's called when you are filtering out water and getting rid of it, discarding it, the UF, the ultrafiltrate. So you can actually choose how much replacement fluid to give back. Let's say I want the patient to get 100 cc's per hour removed from their body, right? So I want them to be net negative, their volume overloaded. I want them to be net negative 100 cc's per hour. Well, you can do some math, and we're just going to simplify. This isn't really how it works, but let's just say that 200 cc's per hour are being, through convection, filtered out of the body and discarded. So I want to actually have replacement fluid rates of plus 100 cc's per hour to get to my net negative 100 cc's per hour, okay? And you can adjust all these things. Sometimes you replace this fluid pre-filter. The filter is the area where convection occurs, where you get rid of water and solute. So if you replace it pre-filter, it dilutes out the plasma passing through. So it reduces the solute concentration. It can lead to filter clogging. Whereas post-filter, you have better solute clearance. So pre-filter, you dilute out the plasma, which reduces the solute concentration and reduces filter clogging. Post-filter, you have better solute clearance, but less dilutional effect and can get more filter clogging. So these are both within the dialysis machine, but you can do it pre or post-filter. So that's replacement fluid rate. What about ultrafiltration rate? So we said the ultrafiltration rate, or the UF, is the rate at which plasma water is being removed through dialysis. This is how much plasma water we're removing from the blood and just getting rid of out of the body. Okay, it's just being discarded. And you can choose the ultrafiltration rate, as we said. It could be net negative 100 cc's per hour, net negative 50, net negative 200, et cetera, et cetera. You get the point. But the UF, the ultrafiltration rate, is how much plasma water is being removed and discarded from the body. So we use this to achieve the fluid balance we want. This is not solute clearance, though, at least not directly. You should think of this as kind of plasma water loss. It can be related to some solute clearance tactics, but it is not a measure of solute clearance. And you just set it based on how much fluid you want removed. That's one of the beauties of CRRT, is I can say, I want this patient to be net negative 100 cc's per hour, so I want my UF to be reflective of achieving net negative 100 cc's per hour. The effluent flow rate is the sum of total of all the things being discarded. So it's the sum of the dialysate, right? If we are CVVHD or CVVHDF, where we are hemodialysis, where we have a dialysate to maintain a concentration gradient for solute diffusion. Remember, that's different than convection. So if we're in one of the modalities where we have dialysate, that's part of the effluent flow rate, because you're obviously just discarding the dialysate. The ultrafiltrate we talked about above. This is how much you're getting rid of plasma water from the body. And then the post-filter replacement fluids, all these things are effluent flow. All these things are being discarded from the body. They're not being put back into the body. And this is important because it helps us actually to determine the dose of CRRT. Usually you target 20 to 25 cc's per kilogram per hour of effluent flow. This is per KDIGO, which is the kidney. I actually don't remember what it stands for right now, but it's one of the big kidney organizations. So when we dose our dialysis, we're choosing an effluent flow based on milliliters per kilogram per hour. And the kilograms, obviously the kilograms of the patient. The thing to note is that higher effluent usually leads to more solute clearance, which makes sense, as we talked about. Higher flow of the dialysate, higher flow of the blood, all that kind of stuff leads to more solute clearance. So you want a higher effluent flow rate if you want more solute clearance, but usually 20 to 25 cc's per kilogram per hour is what people start with. All right. So this is obviously confusing. All these terms can be confusing. We encourage you to definitely check out the study guide and kind of revisit these things, because really it's just with time and repetition and thinking about it, this starts to make sense. So again, you can find that on our Patreon page or YouTube members if that's easier for folks. So mechanisms for solute clearance. My hope is that these are now somewhat familiar, but we're going to try to iron them home. Diffusion and convection are the two big mechanisms for solute clearance. And diffusion, as we said, is a movement of solutes from high to low concentration across a semi-permeable membrane. And this, as we drew, and we'll draw it again, sorry for those listening, you have blood, you have a semi-permeable membrane, the filter, and you have a dialysate. And the dialysate, again, is something that we're spacing out how to spell dialysate now. Dialysate, that seems right. Apologies. The blood flows this way. The dialysate flows counter current, but in parallel. You set the concentration of different molecules in the dialysate, and small molecules like urea and creatinine flow down their concentration gradients into the dialysate to then get rid of in the effluent. Remember, the effluent is what's discarded. Okay, and this is for modalities of CRRT that use diffusion, which means they use dialysate, which are these HD modalities, right? CVVHD, hemodialysis, and CVVHDF, hemodiafiltration. All right, we talked about how the flow rate of the dialysate is what maintains the concentration gradient, and that a higher dialysate flow rate leads to more solute clearance. This is in comparison to convection, the other mechanism for solute clearance. And that's where solutes are dragged with plasma water across the semipermeable membrane. This is actually better for larger molecules like cytokines and myoglobin. And it's really a hydrostatic pressure gradient. So if we draw again, sorry for podcast folks, we have our blood here. We have our filter or semi-permeable membrane here, and there is no dialysate involved. This is that the flow and pressure across this membrane, the kind of transmembrane pressure and the flow of the blood, forces some of the blood through these small pores. And this is plasma water that usually comes across, and this drags solute with it. So some of the solute drags with the water, and then that is what is discarded as effluent, right? So as we said, this is convection is hemofiltration, not hemodialysis. So CVVH, which is hemofiltration, and CVVHDF, which is that combination, hemodiafiltration, right? These two modalities use convection, which is, again, different than diffusion. All right, hopefully that's starting to make a little more sense, although, again, this does take repetition for everybody, me included. So just additional core concepts. These are more advanced, so I think it's reasonable to throw it out there, which is why we included it, but just know these are more advanced. There's something called the Sieving coefficient. The Sieving coefficient is the ratio of solute concentration in the ultrafiltrate as compared to the plasma. And the reason I want to point this out is because it essentially helps you determine how well a solute is removed by convection. 0 being it's not removed at all, and 1 being it's freely filtered. And the reason this is important is because it helps you understand which modality of dialysis is going to be, of CRRT is going to be best for the patient. If you're trying to remove a certain molecule and it does not have any clearance with convection, then you won't want to use CVVH. You won't use continuous veno-venous hemofiltration, because hemofiltration uses convection, and the molecule you're trying to remove is not removed through convection because their Sieving coefficient is 0. Okay, so we just wanted to point that out. Every solute has a different Sieving coefficient. And then transmembrane pressure. I think this one is a little more straightforward to think about, but this is the pressure gradient across the filter membrane. Too high and the filter can clog or clot. But in addition to that, this somewhat drives some of the convection clearance, so it's important to have a little bit of pressure difference too. And the machine usually will tell you about this. So if this gets too high, it might suggest that the filter is clogging or clotting, because that filter clogging or clotting will then increase the pressure gradient across it because things aren't freely moving past that clotted or clogged filter. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.